my topic today is lumbar dermoid excision with lamellar graft and tattooing. I think lamellar, dermoid excision is a very simple topic, but just for the postgraduates and people who are not seen the surgery, I thought this will be very useful. So I'll be discussing with the panelists once the video is The size of the dermoid is approximately calculated for determining the trephine size. Conjunctival resection is done carefully, preserving the normal conjunctiva. After resection, the underlying tenons is also dissected to expose the bare sclera. A corneal trephine is used to demarcate the dermoid extent, and a guarded knife is used to get to the exact plane of cleavage. Once a fairly clear cornea is seen under the cleavage, the dissection is carried forward meticulously, maintaining the plane all through till the limbus. Once the limbus is reached, the dermoid is excised with the conjunctival scissors. Now comes the most important part of the surgery. I usually make a 360-degree groove all around, which will include the scleral part also. This helps the donor lamellar graft to sit well into the groove, creating a smooth graft-host junction. Any bleeding can be cauterized. Now the donor tissue is mounted on the artificial anterior chamber, and the trephine of the same size is used for marking the tissue. The guarded knife is used to mark the plane of dissection, and once the depth is marked, a crescent blade is used to dissect the cornea uniformly all through. The plane is maintained by moving the crescent along a wriggling movement parallel to the artificial anterior chamber. The dissection is carried out in a single plane and also extends beyond the mark to get a smooth peripheral edge. Once the dissection is completed, the donor button is cut with corneal scissors. The inner lip of the graft is trimmed so that the donor tissue sits very well into the groove and there will be no edge lift. The graft is removed and a tribal black tattoo dye is put on the area, and a tattoo machine is used to stain the cornea. The excess dye is washed and the graft is put on the defect and sutured with a 10-0 nylon suture. The depth of the sutures are very critical because superficial ones break fast, leading to poor wound healing. The groove made in the recipient bed helps us to go to the maximum depth due to good visibility at the edges during suturing. The conjunctiva is sutured to the limbus at both the sides. Excess or thick conjunctiva can be trimmed to match the graft edge. So the key pearls in the surgery include making a groove in the recipient bed, trimming the donor inner rim, and making sure that the graft is sutured flat so that you have a perfect apposition at the graft host junction without an edge lift.